This first video is going to focus on acute oxygen therapy.
Hi everybody, my name's David. The purpose of this session is that we're going to talk about the use of acute oxygen therapy in the healthcare setting, particularly secondary care or the hospital setting. What we'll look to cover is we're going to talk about the administration of oxygen therapy, and we're going to demonstrate all the different or the common interfaces that you may see in giving an individual supplemental oxygen therapy. We're also going to highlight the importance of prescription of oxygen therapy, and we'll talk briefly about how we monitor our patients to see a response in the delivery of oxygen therapy. So first off, we're going to talk about the use of emergency oxygen therapy. So this is the delivery of high flow, high level concentration of oxygen therapy in the presence of critical illness. The interface we're going to talk about is the non-rebreather mask, which I'm going to demonstrate to you. This enables us to deliver high and rapid oxygen concentrations between 60 and 90%. The flow rate required to initiate or activate this bag or this reservoir mask is 10 to 15 litres. Whenever you're using this oxygen interface, and remember, this will be for critically unwell patients who require high flow oxygen therapy. When you open the packaging, you're going to find your interface, and you're going to find it connected to a reservoir bag. There will also be some narrow bore oxygen tubing. The first thing to do is to connect the oxygen tubing to the side of the interface. Then what you will do is you'll connect the oxygen tubing to your oxygen flow meter, and you'll turn it to between 10 and 15 litres. The first thing that you must do is that you must occlude this one-way valve, and when you occlude this one-way valve, you will see the reservoir bag will fill full of oxygen therapy. You must ensure that the bag fills more than 2/3 full, and we estimate this is roughly a litre in total that can hold of oxygen therapy. The next step is that you must squeeze the bag just to check there's no problems with the valve, and then re-inflate it again. As you look on this mask, you're going to see the one-way valve that we've just spoke about, and you're going to see another one-way valve on one side of the interface. These one-way valves allow to prevent carbon dioxide rebreathing, hence the term non-rebreather mask. As the patient will breathe in, this valve will open and they will breathe in as pure and high concentration of oxygen as possible. As they breathe out, their inspired gas occludes this valve, allowing for the bag to refill, and their expired gas exits through the one-way valve. You will always notice on these masks that only one valve will be present on the side, and the reason for that is due to safety, whereas if both sides had a valve on it and there was some kind of gas failure, it can increase the risk of doing harm to your patients and suffocation. The interface, as designed, it'll sit over the bridge of the nose and usually here in the cleft of the chin or just under the chin. There will always be an inevitable room air entrainment into this mask, which can dilute the concentration of the oxygen, giving some inconsistencies in the concentration accuracy, hence why we say between 60 and 90%. Patients' respiratory rate and tidal volumes will also make an impact on the amount of oxygen therapy that they receive. To recap, high flow oxygen therapy in the presence of a hypoxemic patient and critical illness. When you're monitoring individuals using the non-rebreather mask, it's important that you're able to look to see that there's a mist coming from the mask, and you're able to see that with every inspired breath, the reservoir bag depletes by roughly 1/3, and then it re-inflates again. The risk is if you don't see the movement of the bag as the patient is breathing in or out, it could be that their inspiratory effort is insufficient and they're at risk of hypoventilation. That in itself can be an early marker that your patient has deteriorated further. As we move on, we're going to talk about the use of acute oxygen therapy. So for individuals or patients who are acutely hypoxemic, but they are not critically unwell and don't need the high concentration of oxygen, we talk about acute oxygen therapy. I'm going to focus it on the Venturi mask interface, which are quite common throughout all of secondary care. The Venturi mask gives accurate and controlled oxygen concentrations, and these are suitable for all populations of patients who require acute oxygen therapy, in particular those individuals who are at risk of carbon dioxide retention, or the CO2 retainers as we commonly refer to them. We can give low flow to high flow oxygen concentrations through the Venturi masks. As you can see, they're different colours, but they're all of similar shape and of size. Your interface, of course, fits over the nasal bridge and, of course, under the chin or between the lips and the lower part of the chin. And you've got your straps to obviously tighten it and adjust it as so. The Venturi barrel, you've got different colours to give different concentrations of oxygen. We start with the blue barrel, and it's known as 24% oxygen therapy. And what you may find, depending on different areas, it will be written on the side of the barrel how much oxygen concentration it is and the flow rate required to activate it. On these type of Venturi barrel, it's actually inscribed at the bottom, 24% at 2 litres per minute. As we move up, we've got the 28% oxygen therapy, and it's run through at 4 litres per minute. The next step up would be 35% oxygen, and it runs through here at 8 litres per minute. Next one up would be the 40% red Venturi barrel, and it runs between 8 and 10 litres per minute. And last, you've got the 60% Venturi barrel, and it runs at 15 litres per minute. The system of how these works, it all depends about the size of these vents, and perhaps these are probably the best two to show the difference between the two. The larger the vents, the more room air that can be entrained, which of course will dilute your oxygen concentration to give a lower FiO2. This one, which is 60% oxygen, obviously has a more narrowed vent to allow the reduction of room air entrainment to give a higher FiO2. The important thing to remember about these is that they're used for acute oxygen therapy, and it's for accurate and controlled oxygen concentrations. Another comment on these is that if you have an hypoxic patient and you correct their oxygen saturations with the appropriate Venturi interface, even though their oxygen saturations are in the desired target range, if that individual still has an increased work of breathing or respiratory rate, you can increase the flow rate of oxygen by 50% of what the recommended initiating flow rate was, as that can help to in some ways match peak inspiratory flow and reduce the respiratory rate. An example of that would be a 28% oxygen Venturi mask running at 4 litres. If I correct my patient's oxygen saturations, but their respiratory rate remains elevated, higher than 25 or 30, I will increase the flow rate by 50%. I will go from 4 litres to 6 litres and look to see if that's made a difference. Sometimes there's apprehension when you increase up the oxygen litres that you're going to increase the oxygen concentration, particularly for those individuals who are oxygen sensitive or CO2 retainers. But with the Venturi barrel, if you increase up your oxygen flow rate, you will not change the oxygen concentration. When we talk about humidified oxygen therapy, again, humidified oxygen therapy is about giving acute oxygen therapy at accurate concentrations ranging from 28% right up to 98%, but it's about giving the oxygen therapy through moisture and heat if required. The evidence behind the humidified oxygen therapy is it can help to reduce upper airway dryness, and it can be more comfortable and better tolerated for patients, particularly individuals who have got quite tenacious or viscous secretions, particularly if that's an underlying condition such as people with bronchiectasis, for example, is that humidified oxygen therapy can play a role in comfort and helping that individual to expectorate their respiratory secretions or toilet their airways, as sometimes is more commonly known. We do use humidified oxygen for individuals who have an altered airway, such as people with tracheostomy and laryngectomy. We don't recommend, or when I say we take that from national guidelines, that there's not a lot of evidence to support the use of humidified oxygen in low flow oxygen therapy or oxygen therapy that's required for less than 24 hours. In relation to what's going on at the moment in regard to nursing individuals with a viral illness such as COVID-19, at this moment in time, there's no strict guidance against the use of humidified oxygen therapy, but understandably, using a water-based circuit can increase the risk of water droplet transmission. So my advice would be to you, if you're considering humidified oxygen therapy, is that you consult your local policy or protocol, discuss with your infection control or your local respiratory nurse specialist. Moving on, we talk about nasal cannula, probably the most commonly seen form or interface of giving oxygen therapy. It allows us to give low or medium dose uncontrolled oxygen therapy. When we refer to uncontrolled, it means we're not entirely sure of the exact oxygen concentration that it delivers. Low flow, typically it runs between 1 to 4 litres per minute of oxygen therapy through the nasal passages, and that can give a rough estimate of between 24 and 40% oxygen. It is, of course, more comfortable for patients. It's easier for them for communicating, eating, drinking, toileting their airways, and just general comfort in the absence of using a face mask. When we use nasal cannula, we don't use it for acute oxygen therapy or for people with critical illness. Usually it's an adjunct that we use for patients who are weaning from face mask oxygen therapy, and of course it's a large role to play for patients or individuals that require long-term oxygen therapy out there in our communities. It can cause some nasal irritation, it can cause increased dryness within the nasal airways, and in some cases can cause a little bit of epistaxis. If we know that patients have got nasal abnormalities, then we try to avoid this form of oxygen therapy. And of course, if they start to get symptoms of it, as when they, for example, if they were to get a nosebleed, then we would consider a face mask oxygen as an alternative. Moving on, we talk about the value of using oxygen prescription, and now is no better time for us to really understand the importance in using oxygen prescription in keeping our patients and our staff safe. So we know that oxygen is classified as a drug and it should be prescribed and dispensed as any other medication, and oxygen therapy is probably the most common medication that is used in secondary health care. When it comes to oxygen prescriptions, we must include a starting dose. We have to know about how much oxygen therapy to give our patients, and that will depend on the cause and the type of respiratory failure that they are experiencing at the time. We need to know the mode of delivery. We need to know which interface is the appropriate interface for that patient at that time. And we also need to know, is this oxygen therapy we're going to use on an as required basis, or is it continuous? Appreciate our more acutely unwell patients who are hypoxemic, it will be a continuous oxygen therapy. We know that coming from national guidance is that every healthcare setting should have some form of standardised prescription chart familiar with staff in order to have a validated and appropriate oxygen prescription. Again, my advice is to look at your local policy and to find out what you guys are using for safe oxygen prescription. This is a common generic example of oxygen prescription, and you can see at the top of the chart it prompts us to ask the question, is the patient a CO2 retainer? So these are populations of patients who are at risk of developing hypercapnic respiratory failure or elevated blood CO2 by virtue of receiving excessive or too much oxygen therapy. The four common patient populations we associate at risk of this are individuals with COPD, morbidly obese or a BMI greater than 35 or 40, people with severe chest wall deformity, and people who have got neuromuscular disease. These patients must be monitored cautiously so we don't cause CO2 retention by giving them too much oxygen therapy. How can you find out the answer to that question? You can ask your patient, because they should have received education if this has happened to them before in the past. You can look at their medical file and you can discuss with next of kin, or if you have any other type of documentation on a local level that can enable you to find that information out. You need to know it's continuous or as required, and it's a tick box session, and then it comes probably the most important part of oxygen prescription, and that's the target oxygen saturation range. You can see that it's given there in that chart. You can see a lower saturation range of 88 to 92. That's specific for individuals who are at risk or are known CO2 retainers, such as the populations I just described, or for probably everybody else, it'll be a saturation range of 94 to 98%. Your goal in oxygen therapy is to correct oxygen saturation to as normal or near normal as possible. As you move down through the prescription, you're going to see there the key at the bottom to dictate what type of oxygen interface we're going to use and how much we're going to give. And if I was to express what's documented there, it would be nasal cannula at 2 litres per minute. It's of course then signed and dated by the appropriate prescriber who's prescribing the oxygen therapy. It will be the nurse's role that on every single drug round, that what they will do is they will look at the patient's oxygen saturations and they will make sure that they are achieving their target oxygen saturation range. If they are not achieving it, then they will need to adapt or modify the oxygen they're receiving to achieve the target saturation. If they are overachieving it, then we will be able to wean it down. The evidence behind this in prescription and monitoring and nurses being able to wean and titrate oxygen therapy is that it is safer for our patients that they receive the appropriate amount of oxygen therapy at that time. As we talk about monitoring, we monitor oxygen or response to oxygen therapy through pulse oximetry, and it should be readily available in every healthcare setting providing acute oxygen therapy. We record and monitor SpO2 as per your National Early Warning Score charts, an example of which is given to you on the slide. We talk about a 5-minute minimum rule, and what I mean by that is that if you're starting individuals on oxygen therapy, we want you to monitor SATs for a minimum of 5 minutes. When I say SATs, I mean oxygen saturation. If you're increasing the flow rate or if you're weaning oxygen therapy, particularly in complete cessation of oxygen therapy, again, 5 minutes minimum, you're monitoring the oxygen saturations to see if they change. And usually the practice that we employ in our local area is that if there's a change or a drop in 3% of oxygen, that's enough to warrant a response or trigger a response or an intervention. If your patient is critically unwell, it would be continuous SpO2 monitoring. When we do ABG indications, so looking at the arterial blood gases, for all individuals at risk of hypercapnic respiratory failure or your CO2 retainers, we will be repeating arterial blood gases after 30 minutes of starting oxygen therapy to see if there has been a change in arterial carbon dioxide. And of course, if your patient is not responding in the way you would expect them to with oxygen therapy, you may need to check their oxygenation in their arterial blood. So in summary, when we manage any individual patient in respiratory failure, we know that it's a multidisciplinary, patient-centred approach. We would consider acute oxygen therapy in all acutely unwell individuals, particularly those individuals at risk or who are actively deteriorating. Oxygen is an essential therapeutic intervention. It must be readily available in all acute care settings, and staff must be appropriately trained in delivery of acute oxygen therapy. And why we're doing this is the promotion of best practice through the safe and appropriate administration, prescription and monitoring of oxygen therapy. Thank you for listening.